Hi, class. Welcome to Module Three's lecture. First, let's start with some housekeeping. I just want to say that I truly understand that the format of this course may be challenging for some students, but I want to assure you that if you're doing the readings, if you study my PowerPoints, which I admit does not necessarily follow best practices for PowerPoints because each slide is loaded with a significant amount of information. But I prepared these PowerPoints in this way so you will have the material necessary for understanding these concepts, for learning these concepts, for clinical practice, and to prepare you for your exams. Okay? So, to recap, if you're doing your readings, if you study my PowerPoints, if you listen to these lectures and review the videos I share with you within the PowerPoints, you will have the knowledge necessary or required to apply in the clinical area for competency. Okay? All right, so let's get into it. Okay, so today we're going to talk about, well, we're going to talk about, let's see, today we are going to talk about psychosis. We're going to look at schizophrenia as a prototype, and we're going to talk about the neurotransmitter networks or pathways. Okay. But I think if we're going to talk about schizophrenia, if we need to talk about, well, we're going to talk about antipsychotics, some antipsychotic drugs. I think we need some context. Okay. Now, I discussed this in my first lecture, but as a reminder, antipsychotic drugs are also known as neuroleptics, and they're used for psychotic-based disorders. Now, remember, historically, antipsychotic drugs were first tested and approved for schizophrenia. But as I mentioned previously, these drugs can be used for other disorders, which we'll talk about later in the semester. But for now, let's talk about psychotic-based disorders. So right now, what I would ask you to do, even though we just started, is to pull out or access your DSM-5 TR online. Pull up the section titled Schizophrenia Spectrum and Other Psychotic Disorders. Pause this lecture and just briefly read over the different disorders. Okay, so pause it now. Okay, you're back. I hope you read over that section. So, in general, a very general description of psychotic disorders or a psychotic disorder is when a person has trouble telling what's real from what isn't. Okay, this is very broad definition. Oops, oops. Okay, all right. So, the core issue is psychosis. And psychosis can be associated with other disorders, not just schizophrenia, spectrum based disorders. For instance, a person can have a severe major depressive episode with psychotic features. Okay, a person with bipolar can have a manic episode that includes delusional thinking or delusions of grandeur. But I want to discuss the hallmark symptoms of psychosis. And to do that, we're actually going to have to look at schizophrenia as a prototype because it's a really clear way to understand the principles that underlie psychotic disorders and psychosis, but also map the neurotransmitter dysfunction theories to each symptom. Okay. So let's consider schizophrenia from a nursing process framework. Now, I'm sure you remember ADPI, right? Assessment, diagnosis, planning, implementation, and evaluation. ADPI. In general, as a psychiatric nurse practitioner, your assessment will include symptom evaluation through the clinical interview, psychiatric evaluation, Observation, you need to pay attention to your patient. Look at your patient as you're conducting your interview, and also by using screening tools and lab tests. And while your initial assessment is going to be different in terms of length and depth, if you will, compared to like your follow up med management assessments, each time you see your patient, you need to assess their symptoms. Are they getting worse? Are they getting better? Are they staying the same? Any new symptoms? What's the efficacy of medication prescribed? Are they compliant? Are they taking any new medication? Any lifestyle changes? Did they start smoking, stop smoking? Are they on a juice diet? Okay. And why? Why is it important to ask about smoking and their diet? And this is because of potential interactions in the CYP, the cytochrome 450 system, right? And we'll learn more about that later in the course. But it's important to keep that in mind, okay? And you're going to use your screening tools um, as an objective measurement of symptoms, but also side effects, right? One of your required readings for this in this week's module is the AIM scale, right? This is the abnormal involuntary movement scale. This should be done each time you see your patient, especially a patient on antipsychotics. Why? Because it's a standardized way to detect, to track, prevent movement-based um, side effects like TD, tardive dyskinesia. Okay. So, in assessing your patient, it's important to understand that psychotic symptoms are characterized into positive, negative, and cognitive symptoms. All right, positive symptoms include hallucinations, delusions, disorganized speech, bizarre behavior, agitation, paranoia. Okay, and cognitive symptoms, we're talking about memory issues, attention problems, and decision making difficulties. All right. And then we have negative symptoms. Okay. And so, negative symptoms, this is your reduced speech, poor grooming, limited, limited eye contact. Okay. Reduced emotional responsiveness, reduced interest, reduced social drives. Okay. So, I embedded this video um, into your PowerPoint, and I also put the link in case you can't access it through the PowerPoint. It's a YouTube video. I would like for you to watch it right now. Um, and I want you to start, if you can, advance to 0.22 seconds because I want you to watch it cold without the introduction and the explanation of what you're going to see. And I just want you to see this patient. Okay, so take a minute, um, take a couple of minutes and just watch this video, please. And again, please start at 0.22 if you can. Okay, and just look at what you see. Okay. All right. So continuing your assessment. Right? So we talked about the AIMS tool. We're going to talk about it again really briefly, but you can use the PANS tool to rate the severity of your patient's symptoms. Right? There's an article in your reading for this week which includes the positive and negative syndrome scale. I encourage you to actually download it and apply it to Gerald for practice. And remember, Gerald is the patient from the video in the previous slide. Okay. And just to highlight, this is a clinician's rated scale. So you're going to assess your patient. This is not a patient reported scale. All right. Okay. Again, to revisit the AIM scale, read the PDF available in this module. again, this is a clinician rated scale. So you're going to assess your patient's movement based on what you observed during the appointment, okay, during the visit. I embedded a video on TD, tardive dyskinesia. You might want to visit that as well. I recommend that, okay? All right. So the next step in the nursing process is diagnosis, right? So you made your assessment, you looked at the patient's symptoms, you utilized your screening tools, okay? So as a psych MP, you're going to diagnose, your diagnoses are going to be made in line with the DSM-5 TR's diagnostic criteria. Okay. And so you can start to formulate a working diagnosis. Now, here are some diagnoses that are cate- categorized under schizophrenia spectrum and other psychiatric disorders umbrella in the DSM-5 TR. Now, because this is a psychopharm class, I'm not going to get into the differential diagnoses, so this is just for context, but you're going to make your diagnoses based on the specific diagnostic criteria as delineated in the DSM-5 TR. Okay. All right. So you're working where you have your working diagnosis. Now you're going to start to correlate the patient's symptoms. So now we're in the planning phase, right? We're going to start to correlate the patient's symptoms, right, with the hypothetical or theoretical dysfunctional areas in the brain. Basically, you're going to say what neurotransmitters and what pathways are involved and what drugs are appropriate to affect change within these individual pathways or affect these neurotransmitters. Okay. Another part of the planning, um, another part of planning would be to consider drug interactions and special population considerations, but we're going to get into that later in the semester. Okay. So again, in general, when you're prescribing, you want to have some rationale, the what and the why. And as much as possible, we want to make connections between the patient's symptoms, what do you see clinically, and correlated neural dysfunction, the neural circuits, pathways, neurotransmitters, abnormalities. Okay. All right. So, hold on. Okay. So, for instance, in schizophrenia, the dopamine hypothesis suggests that imbalances in the dopamine pathways contribute to symptoms. And just remember that schizophrenia is our prototype, right? Okay, so there are four major dopamine pathways in the brain. So first, let's look at the mesolimbic pathway, which originates in the ventral tegmental area and projects to nucleus accumbens in the ventral striatum. Now, if you remember, the ventral tegmental area is one of the areas where dopamine is produced in the brain, right? So, dopamine neurons are located in the VTA ventral tegmental area and project their axons to the nucleus accumbens and where they release dopamine. All right. So the hypothesis is that positive symptoms, right? Your hallucinations, your delusions, your disorganized speech is associated with too much dopamine or an overactivity of dopaminergic neurons in the mesolimbic pathway. Okay. So positive symptoms are associated with overactivity or too much dopamine in the mesolimbic pathways. All right. Next, we have the mesocortical pathway. And so this pathway originates in the ventral tegmental area. Okay. But hold on one second. I'm sorry, it originates in the ventral tegmental area and projects to two different aspects, areas of the prefrontal cortex. All right. And it's hypothesized that there's a deficiency or dysfunction of dopamine activity in this pathway, which contributes to negative and cognitive symptoms. All right. Specifically, the dorsolateral prefrontal cortex is associated with memory issues, difficulty making decisions, and an inability to pay attention. All right. And then negative symptoms are associated with the ventromedial prefrontal cortex, and this is poverty of words, reduced speech, reduced eye contact. Okay. So mesocortical, cortical, cognitive, negative. All right. Now let's look at the nigrostriatal dopamine pathway, which originates in the substantia nigra and projects to the dorsal striatum. All right. Now I want to pull back for a second. Antipsychotic medication, especially first generation antipsychotics, can cause extrapyramidal symptoms, EPS. All right. This is a movement based side effects due to dopamine deficiency or dopamine blockage in this pathway. All right. Now, this is because first generation antipsychotics block D2 dopamine receptors, and it's a strong blockage. It's a strong, a high affinity. Okay. And the nigrostriatal pathway, and in the nigrostriatal pathway, this causes a dopamine deficit, which results in motor side effects. Okay. So if on an exam, they ask you which pathway is associated with EPS symptoms, you now know. And you now understand why as well. And I think it's important that I just want to clarify if a person has, let's say, schizophrenia and has positive negative symptoms, they're not going to have motor side effects until you start, unless they have an underlying disorder of like Parkinson's or something like that. But until you start to give them antipsychotics, and particularly first generation antipsychotics, because it's the medication that blocks dopamine receptors and it causes a dopamine deficiency, which then leads to the motor side effects. I hope that's clear. Okay. And then we also have the um, tuber-infundibular pathway. Okay. And so this pathway originates in the hypothalamus and projects to the pituitary gland. Now, normally dopamine in this pathway is modulates is the release of prolactin. When there's normal amounts of dopamine in this pathway, prolactin is regulated. Okay. But when dopamine D2 receptors are blocked in this pathway by antipsychotics, it leads to an increase in prolactin levels. And this is known as hyperprolactinemia. And so what do you see clinically? All right. Again, this is well, what you see clinically is you'll see galactorrhea. This is the production or discharge of breast milk. So you'll have patients who are not pregnant, female patients who are not pregnant, and you're giving them a first generation and potentially second generation as well, antipsychotic, and not as much in the second generation. And they start to produce breast milk. This is because the dopamine receptors within the tuber-infundibular pathway are being blocked, and this leads to an increase in prolactin. Okay, you might see amenorrhea. You might see libido changes. Sorry, hold on. And you might see gynecomastia. Right? So this slide is just basically a breakdown of the dopamine hypothesis of psychosis and schizophrenia. It's just a visual representation of what we just discussed. And while the dopamine hypothesis of psychosis and schizophrenia does a really good job of explaining positive symptoms, researchers and clinicians have found that it doesn't fully take into account negative symptoms and cognitive deficits. And it also doesn't explain treatment resistant patients. Okay. Now, there's an emerging hypothesis that the nigrostriatal and mesolimbic pathways might not be completely discrete pathways. Instead, they may communicate with each other. And you can read about that more in the text. Okay. All right. So the glutamate hypothesis is offered to complement the dopamine hypothesis. Now, glutamate is an amino acid that acts as a building block for proteins, and it is very important in neurotransmission, right? It's the brain's primary excitatory neurotransmitter. I'm sorry. Its release from glutamate neurons is essential for learning, memory, and synaptic plasticity. Now, one type of glutamate receptor is NMDA receptor, okay, which is really important for prefrontal cortex function. So, this theory posits that in schizophrenia, and remember that's our prototype, okay, um, NMDA receptors are hypofunctional cortex, right? So communication between neurons in the prefrontal cortex is disrupted, which impairs processes like thinking, planning, memory, and decision making. Okay, so NMDA receptor hypofunctioning in the prefrontal cortex is hypothesized to then cause a downstream effect, leading to an increase in dopamine, which we know is associated with positive symptoms of psychosis. Okay, all right. Now, if you remember from our first lecture, we talked about the history of psychopharmacology, particularly how research theories that explain psychosis, schizophrenia, and other psychiatric disorders were driven by how medications affected the brain, right? Now, today we understand that this is a psychosocial biological model, right? That trauma, the environment, stress, psychological resilience also play a role in the development of psychiatric disorders. But studying drug effects has helped researchers hypothesize like what is going on neurochemically in the brain. So let's think about antipsychotics for a second, right? For now, let's talk about first and second generation antipsychotics. So, first generation antipsychotics are strong dopamine D2 antagonists. The second generation antipsychotic have a weaker or a lower affinity dopamine D2 bonds. Second generation antipsychotics also block serotonin 5-HT2A receptors. Okay, so you have first generation really strong D2 antagonists, they receptors, right? And then second generation, you have a weaker D2 dopamine bond to the receptor. Okay, so dopamine bonds weaker to the dopamine receptors, but it also blocks 5 serotonin 2A receptors. Now, even though second generations have a weaker D2 bond and block serotonin 2A receptors, they can still be effective in reducing positive symptoms, particularly visual hallucinations. Okay, so why does that matter right now? Well, when you look at a drug like LSD, right, which is serotonin 5H, serotonin 2A. Okay, 5-HT is serotonin. Okay, so it's a serotonin 2A agonist. Okay, 5-HT 2A agonist. A drug like LSD, okay, it causes psychosis like symptoms, particularly hallucinations. When people take LSD, they see things. Okay, so the effect of LSD led research to the serotonin hypothesis of psychosis, which proposes that hyperactivity or imbalances at 5-HT2A, serotonin 2A receptors, contributes to psychotic symptoms, especially visual hallucinations. Okay? And so on this slide, you'll see things like you'll see I put what is 5-HT, that's serotonin, what class of neurotransmitter is serotonin, what is the precursor for serotonin. This is not necessarily that you know it for this lecture, but you will need to understand it as we move forward. Okay. Okay. So you did your assessment, you have your working diagnosis, you completed your planning by correlating symptoms to possible neurotransmitter and pathways involved, and your next step is going to be implementing your plan. What will you prescribe? Will you order any tests, etc.? Okay. So for next week, we'll pick up here. Okay. All right. This week you have a worksheet, and what I want you to do is use Stahl's prescriber guide, complete the worksheet, which is on Haldor. It's a bunch of questions. What's the class? What's the mechanism of action? What's the side effect profile? Okay, and then we'll go over it. And this is just a list of atypical antipsychotic agents, which again we'll talk about for the next lecture. And I wanted to put in a practice question here because the quizzes are really just to help to reinforce independent learning from the reading. Credit, right? It should be a very simple recall exam. Once in a while, you may have a challenging question, but for the most part, everyone should be receiving an 80 to 100. If you're not, you need to make an appointment and see me because we need to understand what is the issue here, okay, and how I can support you. All right, so this is a practice test that you would most likely see in your midterm or in your final, and I'll read it to you, okay? So this practice question is based on this lecture for the most part. So you should be able to answer this practice question if you understood what we just talked about. Okay, David is a 36-year-old man with a history of schizoaffective disorder. He is diagnosed, which was diagnosed during his first year of college. He has been stable on treatment for several years, but recently lost his job and employer-based health insurance. So remember, when you do your assessment, you want to ask, you want to have develop a therapeutic relationship with your patients, so you can ask them, "Hey, what's going on? How's things? How's work?" You don't want to just come in and say, "How you feeling? How's this? How's that?" You need to have relationships so that you can assess really what is going on with your patient. Okay. He is currently applying for Medicaid, resulting in a disruption in his psychiatric care. David is brought to the emergency department by his father due to worsening psychiatric symptoms. On evaluation, David is observed talking to himself, laughing inappropriately, and carrying on full conversations with no one present. He appears internally preoccupied and is responding to unseen stimuli. All right. So now, based on your knowledge from this lecture and based on the information provided in this practice question, you should be able to answer the next question. So, question one. Based on clinical presentation, the psychiatric mental health MP understands that David is most likely experiencing which positive symptom of schizophrenia? Okay. Now, the question two. The psychiatric mental health MP understands that David's current symptoms are most closely associated with dysfunction in which dopamine pathway? Okay. And then question three, during collateral history, David's father reports that David was previously treated with Haldor for many years. A few years ago, his provider switched him to Abilify because David developed frequent blinking and tongue protrusion. The PsychMP associates these symptoms with dysfunction in which dopamine pathway? Okay. All right. So, let's see. So now, if you have any questions, please feel free to contact me if you need to schedule an appointment. Um, you absolutely can. We can schedule a video meeting. All right. Um, And I hope this was helpful. Okay. All right. Thank you.